Initiative for Health Accountability and Transparency welcome you to CPD Academy Monitor Evaluation Course 2, which is on data sources, data collection, and analysis. CPD Academy is the learning hub for health professionals. My name is MJ Abdullahi, your instructor for this course. Let us navigate the course design and materials. The CPD program on monitoring evaluation is made up of 3 courses. Monitoring Evaluation Course 1, Essentials of MIE. The Monitoring and Evaluation Course 2, which is on data sources, collection and analysis, and is the subject of this video. The third one is Monitoring and Evaluation Course 3, which is on assessing monitoring and evaluation system and developing MIE framework and plan. The course materials include a graded pre-test quiz, which is mandatory for all participants to take at the beginning of the course, the video, the downloadable PowerPoint presentation, which provides more information and details, the graded course completion examination, suggested resources on monitoring and evaluation. Those who choose to have course completion certificate and contain medical education credit will need to achieve 75% pass and pay a token. The Module 1 is on data sources and data collection. The outline will include definition of data information and data management, definition, components and characteristics and challenges of health information system, types of data sources and collection, and we also look at dimensions of data quality. On the learning objectives, the participants will be able to define and explain the differences between data and information, distinguish between routine and non-routine data, understand the various sources of data, also understand the concept of health information system, discuss routine and non-routine data collection methods, and describe the various dimensions of data quality. The world is becoming more and more data-driven with endless amount of data available to work with. Data refers to raw numbers or other measures which are usually discrete and gives objective facts about events. It is a set of values of qualitative and quantitative variables about one or more persons or objects or even events. Data can be of 2 types. We have primary data, which is directly collected by going to the feed, and secondary data, which is generated from published resources like articles and theories. Best quality data means nothing if not properly analyzed, transformed into information, and used for decision making. Information refers to facts provided or learned about a situation, person, event, or something. Quite often, it is the outcome of data processing, analysis, interpretation, and presentation, during which data is transformed into a message after processing. In the context of monitoring evaluation, valuable information only becomes available with proper data management. What then do we mean by data management? Data management refers to the collection, storage, processing, dissemination, and efficient use of information. It is an essential component of any intervention, project, or program. Just like we have just described, data management is more or less or basically a data transformation process. Data collection and coding, then analysis, which involve data processing, interpretation, and presentation. And then when we have or we generate evidence for action, it's used by politicians, it's used for programmatic operations, and also it helps us to secure commitment from key stakeholders. Let us look at classification of data types. Data can be categorized either as hard or soft. What is hard data? Hard data is verifiable and generated from reliable sources according to a robust methodology. It's directly precise, measurable, factual, and indisputable. Hard data are often numerical or coded according to a protocol. They are reproducible and likely to be similar even if the data collectors are varied. While on the part of soft data is based on qualitative information such as a rating or survey or poll. It attempts to capture human experience and is often narrative or in a textual form. It's pervaded with some subjectivity due to the complexity of personalities of the data collectors and individuals that are being studied. Let us look at what we mean by health information system. A system that provides specific information support to decision-making process at each level of an organization. It is similar to health management information system. The subject of National Health Management Information System will be a subject for another course. The components of health information system can be described from three perspectives. The information process, which basically consists of multiple operationally defined indicators, the baseline and data values, appropriate data sources and collection methods that are clearly defined, well-defined data transmission, processing and analysis process, feasible data collection plan, budget. On the aspect of management, basically it involves resources, organizational guidelines, and clear roles and responsibilities for various stakeholders that are involved in data or information management. Then the need for information for decision is often to be made available to politicians and also for program operators. Let us now look at the characteristics of health information system. We can look at the four distinct characteristics. Health information system is an integral part of health system. In fact, health information system is a building block of the health system. And one of the characteristics is that it generates data and information and is often responsible for quality data production and continuous use of health data. These are key issues that the health information system provides. There are myriads of problems and challenges with health information system, some of which include irrelevance and poor quality of data that is collected. There is fragmentation into program-oriented information systems, which often results in duplication and waste. There is centralization of information management, and rarely is there feedback to lower levels. There are the issues of poor, inadequately used health information system infrastructure. There is often the question of inadequate infrastructure for health information system. Poor use of information by users at all levels is common, care providers as well as managers and even the communities and other stakeholders. There is a block between facility and community health management information system. They rarely integrate. There is quite often reliance on more expensive survey data collection methods. Data sources and collection can be categorized as either routine or non-routine. And routine refers to collection and collation of data which is regular and is also regularly made available and is also based on well-defined protocols and standards. While for non-routine, it refers to collection for a particular purpose without the intention of regular repetition or even adherence to established standards. There are examples of data sources. Routine data sources will include routine service reporting, which is usually healthcare service reporting, epidemiological surveillance. There are spatial program reporting systems, cancer reporting systems, for example. There are administrative systems that report some other aspects that are non-clinical in the health system. The vital registration system is very key and is important for health sector. Demographic surveys, censuses, and also spatial studies or program evaluations. These often provide routine data sources. For non-routine data sources, they include DHS, spatial surveys, program or project evaluation, clinical trials, epidemiological survey, which may be descriptive or analytical. Let us look at classification of data sources by program. Sources of data differ depending on the type, goals, and objectives of a program, and they can be categorized into two: demographic and socio-economic characters or features of a study population that has to do with age, sex, education, occupation, mobility, and geographical distribution. You also have health status sources, which deals basically with health service use data, diagnosis, interventions, procedures, health outcomes of interventions, morbidity, mortalities, and even uses of health service. Data sources can be classified by levels, and the first is policy or program level. This is policy legislation formulation level primarily, and sources of official legislative and administrative documents, national budgets, or other related data. It also involves policy inquiries, reputational rankings, program effort scores. It also involves tools, indexing questionnaires for country specialists and rankings, and special contract studies. There is also the facility level data source, and it includes services, infrastructure of facilities, audits and inventories, facility surveys, healthcare providers and staff, and also performance reviews and competency measures that are put in place, including training records. When we look at population level, is where you need to know the size and composition of a population. Sources include Population Census Bureau, where you can also have information about centennial surveillance systems, vital statistics registration, sample house surveys or individuals. You also have tools, birthday certificates, census questionnaires, household and individual spatial surveys. There is also another level, which is the service environmental level. This level requires different types of data from sources such as administrative records, like health management information system data, financial and transport data. There is also the service delivery point information, audit information, inventory fertility survey data that has to do with environmental issues. There is staff information, performance assessment, training records, provider data, and quality of care data. There are also client visit registers. There are tools basically which deal with health service information system like facility sample surveys, facility records, performance monitoring reports. And of importance too is the individual client level. Individual refers to a client, participant, patient, or document related to a single person, as can be obtained from sources such as medical records, interview data, case surveillance. There is also the provider-client interactions, and the tools will include case reports, which include survey, questionnaires, client register analysis, patient flow analysis, which can also equally be done or mostly by direct observation. The individual level also measure program exposure, represented by utilization as well as service experience, quality of care, service delivery, disease surveillance. And questions usually are, is the volume increasing? What is the service mix? Who are the clients? How does it vary by public-private sector? What are the consultation experiences? Who they return or recommend services to others? And there could be some other questions. On the individual level too, there are client exit interviews, case surveillance, particularly with respect to epidemiology, provider client observation, service delivery point records and registers, patient flow analysis, and some very significant others. We must not forget the spatial geographical level as a source of data. These are modern, specialized, and advanced level of data sources which gives geographical distribution of events or population measures or events. Sources include cadastral maps, which basis highlights the land ownerships, land demarcation departments with satellite imagery and area photography, digital line graphs and elevation models, and tools. Most importantly, we should not forget GPS, which is Global Positioning System, and also the computer software program for geographical level data sources. There are key considerations on sources of data, and they include assess the type of information the program needs, assess what information is already available, and what other sources and levels can we avail ourselves. Use those sources to help developing your own MIE plan. Decide what gaps need to be filled and plan for it accordingly. Let us look at data collection. What do we mean by data collection? Data collection is an act of gathering or harvesting data in monitoring evaluation to assess performance or outcome or effect of an intervention. There are types of data collection methods, just like we have described the types of data before. You can talk about routine or regular data collection, or non-routine or periodic data collection. Types of data collection, particularly with regards to routine regular data collection, will include health service reporting, epidemiological surveillance. For non-routine or periodic data collection, basically there are surveys and spatial studies, annual program report, spatial program reporting system like we have mentioned before for cancer or for spatial immunization programs. The non-routine data collection includes administrative systems, vital registration systems, also facility surveys, household surveys, census, research, and also spatial studies. Now, we need to also look at data collection tool. Data collection tool refers to devices or instruments used to collect data. It is important to decide the tools for data collection because programs and research are carried out in different ways and for different purposes. Use of quality tool ensure we capture quality evidence that allow analysis to lead to formulation of convincing and credible answer to the questions that are posed at the beginning of an intervention. Facility surveys are often used as source of MIE data. They have great advantage, but they have their strengths and limitations. They can cover both public and private health facilities. Timing can coincide with program implementation, can combine with population survey for outcome monitoring and impact evaluation. However, their limitations include survey sampling design analysis may be complex, it may be expensive, it may also be time consuming. Information is rapidly outdated unless it is repeated. Surveys are common, but we must also know when they are appropriate, and we must ask questions. When are they appropriate? Surveys are usually useful when other data are not available or inadequate, when they can be tailored to fit specific measurement objectives, yield cost-efficient data on population and services, good sampling techniques, produce representative results for facilities providers and clients. We should not also forget that surveys are expensive, but they are versatile and widely used. Rapid appraisals or qualitative measures are often used, and they include key informant interviews, focus group discussions, community interviews, and also direct observations. There are often questions about frequency of data collection. It could be routine or continuous, and they can be non-routine or periodic data collection like we have described earlier. For routine or continuous data collection, usually health facility-based, patient information and service statistics are often targeted. Community-based, usually service statistics. Program-based, normally administrative. Vital registrations can also be targeted, and also centennial reporting or demographic surveillance. When you look at frequency of data collection for non-routine, it is periodic data collection, and it can be household or facility-based surveys. It can be population census. It could be rapid assessment procedures, and it can also be spatial studies research. Let us take key considerations in data collection. You have to decide the kind of data to be collected to monitor and evaluate your program. Select the method to be used for collection. Design the tool for collection. Give roles and responsibility for the collection. Develop data collection plan guideline containing who, when, and where data will be collected. And anticipate next steps: data collection, collation, storage, analysis, reporting, dissemination, and use. Let us take the first brainstorming session of this course, and it's going to focus on dimensions of data quality. Take few seconds and note down in keywords or points on your understanding of dimensions of data quality. Data quality dimensions. Data quality is an important issue that should be considered in health operations and project management. However, there are several dimensions to data quality. Data quality has issues with completeness, with consistency, with conformity, with accuracy, with integrity, with timeliness. Now, let us look at accuracy first. Accuracy is more or less about validity. It means the extent to which the results really measure what they are supposed to measure. If the data you are collecting for immunization, does it help you to measure immunization coverage? Can you use it to identify dropouts and program accordingly to address it? If a method measures what it claims to measure, and the results closely correspond to real-world values, then it can be considered valid. We also look at validity in terms of the data that correctly reflects the real world or an event being described. Questions you can ask yourself: do data objects accurately represent the real-world values they are expected to model? Data validation ensures that the data complies with the requirements and quality benchmark. Let us look at completeness. Completeness means data meet expected comprehensiveness and expectations. Questions that are usually asked when we are discussing completeness is all the requested information available? Do any data values have missing elements, or are they in an unusable state? When we discuss data quality consistency, it means data across all systems reflect the same information across programs operations. And questions that can always be asked about this includes: are data values the same across the data sets? Or are there any distinct occurrences of the same data instances that provide conflicting information? The issue of data integrity means validity of data across the relationship and ensures that all data in a database can be traced and connected to other data. The questions often asked as part of integrity test is there any data missing important relationship linkages? The inability to link related records together may actually introduce duplication across data systems. Conformity is very important. It means the data is following the set of standard data definitions like data type, size, and format. And questions usually concern, do data values comply with the specified formats? If so, do all the data values comply with those formats? And we have also talked about timeliness, which means whether information is available when it is expected and needed. Timeliness of data is very, very important. Let us take a brainstorming feedback from the last exercise. Did you correctly note down some of the dimensions of data quality? If you do not, you may wish to take steps back to go over the slides on the dimensions once again. There are many factors that influence data quality and use. The factors could be technical, they could be system and environmental, and they can be behavioral. Technical issues include the standard indicators, the data collection forms, appropriate IT technology in terms of availability and adequacy, the data presentation, is it appropriate, and then the availability of trained people. Basically, these are all technical issues. When you come to system and environmental issues, basically the resources. Do you have the resources? Is it sufficient? Is it adequate? The structure of the health system is also very important. The roles and responsibility and organizational culture. On the behavioral factors, they include motivation of data collectors, of healthcare providers, the attitudes and values that are attached to data issues, the confidence, and also the sense of responsibility in those that have been tasked with the responsibility of managing data. Assessing appropriateness and usefulness of data sources is very important, and it is about inquiry on fitness for purpose by asking whether the data source is fit for the purpose for which they are intended, the conclusion to be drawn, and the decision to be made from the available data. Issues to consider in judging appropriateness and usefulness of data and the sources include the technical issues. And basically the technical issues will include, are the definitions clear and appropriate? Are the target and study population clear? Are the data collecting methods clear and sound? How complete, accurate, relevant, and timely are the data? These are basically technical issues. You also have to look at issues relating to outcome or decision involved. It includes, is the study population sufficiently representative of the target population for the purpose of decision? Usually, because you will make inference and generalization. Do you need absolute or relative estimates to make the best decision? Could existing data sources suffice by using comparative data or by extrapolating with care? Would qualitative information suffice when habit automatically suggests quantitative data? Let us look at data management. Data management refers to the process of applying numbers to objectives according to a set of rules. The scales of measurement can be variable, it can be nominal, it can be ordinal, it can be interval level, or it can be ratio. What do we mean by nominal data? Nominal data assign numbers to objects where numbers have no real meaning, other differentiating between objects, or give the name and category for each object. For example, could be gender, which can be male or female. It can be ordinal data, which assign numbers to objects like nominal, but here the numbers have also meaningful order. It indicates rank or placement like 1, 2, 3, 4, 5, 6, etc. Example, place finished. The interval level Numbers have order like ordinal, but there are also equal intervals between adjacent categories. Example, temperature in degree Fahrenheit. The difference between 70 degree and 71 degree is the same as between 45 and 46 degrees. Now, looking at the ratio level, differences are meaningful, like interval plus ratio are meaningful. And there is a true 0 point. Example, amount of money minus 0 money indicates the absence of money. Now let us look at Module 2, which is on data analysis, presentation, and interpretation. The outline of this module basically is overview of data analysis, the purpose of data analysis, steps in data analysis, statistical and MI concepts in data analysis. The basic objective of this module and the session is that the participant will be able to give an overview of data analysis, understand the purpose of data analysis, explain the steps in data analysis, also define statistical and MI key concepts in data analysis. Data analysis is a process of inspecting, cleaning, transforming, and modeling data with the goal of highlighting useful information, drawing conclusions, and supporting decision making. It is used to evaluate data with statistical tools to discover useful information using a variety of methods like data mining, data visualization, data analytics. Data analysis process proceeds from raw data to analysis and generation of evidence-based information or idea. Data analysis has multiple facets and approaches, and it encompasses diverse techniques that I've mentioned, such as data mining, analytics, and data visualization. In today's business world, data analysis play a role in making decisions more scientific and helping businesses operate more effectively. Let us look at the various steps in data analysis. It starts with defining objectives. Start by outlining some clearly defined objectives. To get the best results out of the data, the objective should be clearly defined. The next is posing questions. Figure out the questions you would like to be answered by the data. For example, do children of low-income class miss out immunization? Then, the next will be data collection. Collect data that is useful to answer the questions. In the example we just cited, hospital records, immunization survey can provide answers in this respect. The another stage is about data scrubbing. Raw data may be collected in several different formats with lots of junk values and clutter. The data is cleaned and converted so that data analysis tools can import them. It's not a glamorous step, but it's also very, very important. Then there is the issue of data analysis. Import this new clean data into data analysis tools. These tools allow you to explore the data, find patterns, and answer what-if questions. This is the payoff, and this is where you find results. And the last one has to do with drawing conclusions and making predictions. Draw conclusions from your data. These conclusions may be summarized in a report, visual, or both to get the right results. What is the purpose of data analysis? The purpose of data analysis is to extract useful information from data and take decisions based on the analysis. The answering questions. Provide answers to programmatic questions such as, is my program meeting its objective? Analyzing situations helps to compare program targets and actual program performance to learn how far you are from the target. And also the purpose is interpreting results, why you have or have not achieved the target and what this means for your program. It is to be noted that best quality data means nothing if it is not properly analyzed or if it is not just analyzed at all. Quite often, more information may be required to answer these questions. There are two types of data. Data can be descriptive or it can be inferential. What is descriptive analysis? It describes the sample or target population in terms of demographic and clinical characteristics. It does not define causalities, tell you what, but not why. Example is average number of clients seen per month. These are descriptive analysis. There is inferential analysis. Inferential statistics allows you to make predictions, inferences from a data. It allows to do what we call generalization from sample and about general population. It compares two or more variables to make inference. Let us look at some statistical terms in data analysis. The common statistical terms include ratio, which is comparison of two numbers expressed as A to B or A per B or AB. It is used to express such comparisons as clinicians to patients or beds to clients and is often calculated as A over B. Example, in local government X, there are 600 nurses and 200 clinics. What is the ratio of nurses to clinics? Primarily is 600 over 200, which is 3 nurses per clinic, or a ratio of 3 to 1. There is also the use of proportion, which is a ratio in which all individuals in the numerator are also in the denominator. It is used to compare part of the whole, such as proportion of all clients who are less than 15 years old. Example, if 20 or 100 clients or a treatment are less than 15 years of age, what is the proportion of young clients in this clinic? And primarily is 20 over 100, which comes to 1 over 5. There is also the percentage issue. A percentage is the number or ratio that represents a fraction of 100. It is often denoted by the symbol percent or simply as percent. The percentage value is computed by multiplying the numeric value of the ratio by 100. Example is, if 50% of total number of babies delivered in a labor room are male, that means that 50 out of every 100 newborn are male. If there are 500 babies, then 250 of them are males. There is the rate. The rate measured with respect to another measured quantity during the same time period, used to express the frequency of specific events in a certain time period, like the fertility rate or the mortality rate. Numerator and the denominator must be from the same period, often expressed as ratio per 1,000, like mortality or like the birth rates. There is also the mean. The mean is the average of the numbers. You add up all the numbers and then you divide them by how many numbers that are added. There is also the median, and the median is the middle number when all the numbers are assorted in ascending or descending manner. The details of this can be found more in the PowerPoint presentation. What are the key messages here? Purpose of analysis is to provide answers to programmatic questions. Descriptive analysis describes the sample and target population, but they do not define the causality, that is, they tell you what, not why. Inferential statistics allow you to make predictions or generalization from a data. It compares two or more variables to make inference or generalization. Let us look at section 2 of this model, which is basically on data presentation, and is going to talk about summarizing data and also tables and graphs. Learning objective is that the participant will be able to understand different ways to best summarize data, choose the right table or graph for the right data, and also understand the different ways to present data. Tables are actually the simplest way to summarize data. Data are presented as absolute numbers or percentages. And when you look at charts and graphs, there are visual representations of data. Data are presented as absolute numbers also, or as percentages. The basic guidance for summarizing data is that you must ensure graphs have a title, label the components of the graph, indicate data source with date as much as possible, provide number of observations, which is n is equals to x as a reference point, and where necessary add footnote for more information, particularly when needed. These are examples of frequency tables which clearly set out categories with numerical counts. This is a relative frequency table which is based on the number of values with an interval divided by total number of values in the table times 100. Tables gives percentage of births by decades as indicated here. The source of data and the time is clearly stated. There are the charts and also graphs. Charts and graphs are used to portray trends, relationships, and comparisons. The most informative are simple and also self-explanatory. Use the right type of graphic. Charts and graphs. Bar charts allow comparisons, shows categories of data. Line graphs display trends over time. Pie charts show percentage or proportional share. These are bar charts. They help us to compare categories, as you can see here. Site 1, Site 2, Site 3. And this is a good example of percentage of new enrollees tested for HIV at each site by quarter. This is also telling you, asking question, has the program met its goal? Percentage of new enrollees tested for HIV at each site by quarter. And you can see the target you have. Start bar represents components of a whole and compare wholes. Like you can see here, this is a whole and is divided into two colors. So it shows you the components of a whole and also compare whole. This is a line graph which is showing the number of clinicians working in each clinic during years 1 to 4 of a particular project. You can see Site 1, Site 2, Site 3. There is a pie chart which is contribution to the total, that is 100%. Percentage of all patients enrolled by quarter, you can see there. Let's quickly look at the Module 2, Section 3, which is the final section and is about interpreting data. Interpreting data, primarily the outline of this particular section is interpreting data for programmatic relevance. And basically, at the end of this module and session, participants will be able to interpret data for programmatic relevance, explain data sets, discuss relevance of findings, determine possible causes, and also identify other sources of data. When we interpret data, the first question we ask is the finding relevant? Adding meaning to information by making connections and comparisons and exploring causes and consequences. Usually, the first step is relevance of the finding. And does the indicator meet the target? How far from the target is it? How does it compare to other time periods or other facilities? And are there any extreme highs and lows in the data? These are few questions that can be asked. The next is possible causes. Supplement with expert opinion and others with knowledge of the program or target population. That's why it's important to explore learning and also share knowledge. The reasons for the finding. You consider other data sources. Use routine service data to clarify questions. For example, you want to calculate nurse to client ratio, review commodity data against client load, use all data sources where possible. Other sources of data can include situation analysis, demographic and health surveys, performance improvement data, which you can outsource. As part of interpretation, sometimes you will need to conduct further research. There could be data gaps, and once you have data gaps, you have to conduct further research. The methodology will depend on questions being asked and resources that are available. Let us look at the key messages. Use the right graph for the right data. Tables can display a large amount of data. Graphs, charts, visuals are easier to detect patterns, so you must always go for them. Label the components of your graph as much as possible. Interpreting data adds meaning by making connections and comparisons to programs. Service data are good at tracking progress and identifying concerns, but they do not show causality. The bedrock of data analysis and interpretation is formed by the collection of data. Data is basically unorganized statistical facts and figures collected for some specific purposes, such as analysis. There are different sources of data and different methods of data collection depending on the type of data. Data quality is an important issue that should be considered in health operations and project management. The main purpose of data analysis is to extract useful information from data and take decisions based on the analysis. There are further resources for reading and monitoring evaluation which have been listed here. There are many others that you can explore that are not listed here, but can be very useful to you to give you further insight into the subject matter of monitoring and evaluation. Don't forget, there is a downloadable PowerPoint as part of the training material for this course. You try to avail yourself with this for more information.